Good afternoon to everybody, and as usual, it's always a pleasure to be, if not factually, but virtually connected with Dhaka. And thank you very much, all the professors, to give me this opportunity. So this afternoon, I'm going to talk a little bit of current concepts on aortic stenosis, largely trying to highlight asymptomatic severe AS and low flow, low gradient aortic stenosis. To start with, let me just talk about a little on asymptomatic severe aortic stenosis. The biggest problem is, are asymptomatic aortic stenosis patients really asymptomatic? So if you look at the guidelines, the indications for valve replacement, whether it is America or whether it is Europe, both of them say that if the symptoms occur in a severe aortic stenosis, it becomes a reason for you to change the valve. Second important valve replacement indication, which is more from European side than from the American side, is hypotension on exercise, which is a class 2A indication. So how are symptoms defined? Symptoms, everybody has symptoms on stress, and that's the reason why you should always try to find out whether these symptoms are of cardiac origin or not. And here comes the role of stress tests. So at what level of exercise? If your level of exercise is less than 5 bends, you are pretty sure that you are not dealing with a very high or a very good prognostic indicator. And these people qualify to get their hearts changed, valves changed. How is hypotension defined? So our understanding of hypotension was that whenever there is a fall of blood pressure on exercise, but it is actually not the fall of blood pressure, it is failure of blood pressure to increase more than 20 millimeters of mercury. So even if there is not a fall actually, but if there is a failure to increase blood pressure more than 20 millimeters of mercury, it is kind of labeled as a hypotensive response, if not hypotension. So should asymptomatic patients with severe AS undergo AVR? And when are they really asymptomatic? So if you look at this cartoon, this is a severe aortic stenosis, where what you need to do is, you know that there is a calcific aortic valve, there is a mitral annular calcification. The man is fairly elderly because of his mitral annular calcification. And if you look at this next step forwards is to look at the gradients, look at the aortic valve area by aortic valve continuity equation. And then also you can see what it is. So once you have a picture of this sort, you know you are dealing with severe aortic stenosis. And you look at the velocity, it is 4.6, the mean VG is 52, and aortic valve area is 0.7. So fortunately for us, across the Atlantic, things have reasonably well sorted out, because otherwise, when we were talking about the mean gradients, Americans used to call it 40 millimeters of mercury, and the Europeans used to have it 50 millimeters of mercury. But now, regardless of where you are on the globe, the severity of AS is defined as if your max velocity is more than 4, mean velocity is more than 40 millimeters of mercury, and by aortic valve area continuity equation, if your area is less than 1 square centimeter. So we were looking at this 84-year-old man with severe AS. What do? Wait and watch. More data, more testing, or aortic valve replacement when he becomes symptomatic, maybe at the age of 90 years or whatever. Look at the natural history of aortic severe stenosis. Now, this is a data from Otto et al. So this is event-free survival here. And the moment people have a velocity more than 4, they start declining as far as their attrition is concerned, or their survival is concerned. So attrition is more, survival is lesser the moment there is a Vmax, which is more than 4. This was again proven by Rosenhack, it was proven by Pellica, it was again proven by Stewart, and Rosenhack did further more evaluation, that he further had divisions by availability of the calcium in the aortic valve. So this became one of the ancillary or surrogate marker for severity of aortic stenosis. If there is a moderate or severe calcification, it is a marker of severity. So larger the calcification, severer is the aortic stenosis. This was taught to us by Rosenhack. Here are certain more subsets by Rosenhack, and he said that the gradients are also indirect markers for survival. I will tell you the understanding difference. Keep noting this, that larger gradients means earlier attrition. Larger gradient means lesser survival. And this is all for asymptomatic aortic stenosis, which was done by Rosenheim. Now, where are we? Where is the risk of death while waiting for symptoms to trigger AVR? This is the natural history which has been documented by Pai. He actually couldn't find a place in very circulation or other, and he had to get this published in Annals of Thoracic Surgery. This is all against the conventional thinking that we had about asymptomatic aortic stenosis, where they said that for asymptomatic aortic stenosis, wait and watch, wait and watch, wait and watch. Pai said, don't wait and watch. The moment you have severe aortic stenosis, attrition starts regardless. So was it proven by the gradient studies, where they found that when the gradients were larger, the attrition started. So where is the disparity? The discordant thing is that Kang et al. Said, no, watch patients till such time. Nistri said, watch patient till such time. And Taniguchi said, watch patients till such time they become symptomatic. Now, where is the disparity? So Taniguchi had two sets of patients done in asymptomatic aortic stenosis. He had equal number of patients. One followed the conservative route, another had an AVR in asymptomatic aortic stenosis. Now, the graphs were divergent, but there is a subset of people who are believers in their own concept. And there is a very strong belief globally that if the patient is asymptomatic with aortic stenosis, do not operate, or do not change their valve regardless of how you do it. Now, this is what the divergent graphs were at the end of 5 years. People who had conservative treatment died more, but the purest or the believers in the concept, they came out that 31% of patients who developed symptoms did not have an AVR, so they died. So 17 died, and then it became the significance or statistics. The p-values were not significant. So this is a disparity, and the debate continues. So now we are looking at further more refinement of indications for valve replacement surgery, which may not be class 1 indication. But if you look at the American College of Cardiology, if there is a Vmax which is more than 5 meters per second, that means the gradients are greater than 100, it's a class 2A indication. If there is a rapid progression and low surgical risk, it is a class 2B indication. So class 2B indication, we can sideline it because class 2B is very close to 3. But if this is there, then this needs to be addressed cautiously. Now, Europeans are a little more conservative compared to the Americans. And in European side, instead of 5 Vmax, it is 5.5 meters per second, which becomes an indication, class 2 indication for surgery. Not only that, there is yet another indication, which is severe valve calcification and rapid progression, class 2A. And people are talking about elevated BNPs, increase in gradients with exercise more than 20 millimeters of mercury, excessive LVH. These are all some softer indications which are being studied. So regardless of which side of the Atlantic you are, the guidelines have lowered the threshold for surgery in asymptomatic patients with AS. And if you look at this, it is to be calculated by severity of AS, severity of calcification, left ventricular function, and exercise response. So let's look at what does the severity of calcification show. So this was a study which is almost 8 years old, where they said that if your mean gradient is less than 40, the men, if they have a calcium score of only the aortic valve, not coronary, only aortic valve calcium score greater than 20, 65, as in 2065. And for women, if it is greater than 1274, then the high chances that the area is less than 0.6 centimeter per meter square. What about BNP? BNP is yet another thing which is being very, very aggressively evaluated. If, say, for a population, the BNP ratio is 1, and if it is greater than 3 in a specific patient, then these are the patients who have a lesser of a survival, and these probably are the candidates for surgery. Other novel biomarkers are being studied, which is HS-troponin-I, GDF15, soluble ST2, and NT-proBNP. Now to introduce one more concept, which is easy to understand for poor LVs, that is low flow, low gradient. So in case the LV is poor, and then you know that the reason why the gradients are not being produced is because the LV is poor. Easy to understand. So what you do is you give dobutamine, you do catheterization, you do advanced imaging like transesophageal echo, you do calcium scoring, and you find that the patient has severe aortic stenosis. You are good with that. The more difficult to understand is low flow, low gradient, severe aortic stenosis, and normal LV. Now, this is a difficult thing to understand, because how is it that the normal LV is not generating gradients that with a severe aortic stenosis? So there are few reasons and hypotheses why people have found these kind of things. And the reason is that the hypertrophy is so much that very little of volume enters into the LV. And when it contracts, it ejects so little that the gradients are not produced very significantly. Second is that, say, if the earlier echo was a 74% ejection fraction and now it has come to 55%, so this will behave exactly like severe aortic stenosis, low gradient, low flow with LV dysfunction. Because from 70%, if it has come to 50% or 55%, it is a poorer LV. This is again a hypothesis. And third is that try to control hypertension before labeling it, because larger the hypertension, the lesser is the gradient. So treat hypertension, and if there is confusion, continue with catheterization. So this is a little tricky understanding. The only thing is that how do you sort it out? You sort it out by doing valve calcification and advanced imaging like aortic valve area by transesophageal echo. And important is that you must trust your clinical sense. What do you do? So if there is an outcome impact of aortic replacement in patients with preserved ejection fraction and low flow, low gradient, you look at this mortality. If you do AVR, it is a little protective, but lesser so for low gradient AS, higher so for high gradient AS, which is understandable. And what is happening, the numbers were so little that it has not come into the guidelines yet. So how do you sort out the diagnosis? So for low flow, low gradient, severe aortic stenosis expectedly, do an dobutamine stress echo and look at the Vmax. If your Vmax is more than 4 or your mean PG crosses 40 millimeters of mercury and the area by continuity equation falls lesser than 1 centimeter square, it is a class 2A indication. This is the recommendations from the American side. The Europeans are a little more evolved in the sense that they have introduced a data that with contractile reserve also you can sort it out. Now, this is easy, that you have low flow, low gradient, poor LV. What about normal LV? So normal LVs qualify only if clinical, anatomic, and hemodynamic data support severe aortic stenosis, not otherwise. For European side, it is only after thorough confirmation of severe AS that you have to subject these patients for 2A. Now, how do you diagnose normal flow, low gradient aortic stenosis? AVA less than 1, indexed aortic valve area less than 0.6, mean pressure area less than 40, and stroke volume index more than 35 ml per meter square. So how do you diagnose classic low flow, low gradient? Here, everything is almost the same except that the ejection fraction is low and your stroke volume index is less than 35. How do you diagnose paradoxical low flow, low gradient? So paradoxical is same as like what I said, severe aortic stenosis, normal LV, low flow and low gradient. Here, what you have to do is you have to calculate valvular arterial impedance, which is more than 4.5. This has been in existence since almost a decade, in fact, more than that, but it has never caught the favor of people who are doing it practically, because I'm not too sure whether it should be included in routine practice or not. But to see this, you have to, if you have an area of less than 1, which is something like an index aortic valve area less than 0.6 centimeters square per meter square, mean gradient less than 40, ejection fraction more than 50, and systolic volume index of less than 35, then you can be sure that you are dealing with a paradoxical aortic stenosis. There are a few more criteria which should be completely available to you. The end diastolic dimensions should be less than 45 and diastolic volume should be less than 55. The mitral annulus systolic excursion should be less than 8. Longitudinal strain, if it is less than 14, it helps, because this is what I was saying, that ejection fraction was earlier 70%, now it has fallen to 55%. So these patients are going to behave like low flow, low gradient, poor LV. And how do you prove that? By doing a global longitudinal strain. Relative wall thickness also, if it is more than 0.5, and ratio of 2 times posterior wall thickness to LVED is suggested. Do some MRIs, and if you find myocardial fibrosis on MRI, you are pretty much sure. So there are several types of prosthetic valves, the tissue valve, the metallic valve, and now we are looking at newer dimensions to be mentioned, because there is something known as TAVR. I'm sure at some point of time in Dhaka and Bangladesh also, this will become a very routine phenomena. But when, as echocardiographers, we are sorting out, you have to rule out subaortic membrane, you have to find out the distance of coronary ostia from base of aortic valve leaflets, and that should be more than 10 millimeters. Large calcific valvular nodules or not, you have to be careful. Highly calcified aorta, aortic root dimension should be less than 45 millimeters at the sinotubular junction. Very hypertrophied septum, be careful. Just now we finished one very hypertrophied septum, but touch wood, everything went off well. Annular, aortic annular size less than 18 should be seen with caution, and more than 27, because the size of the valves available usually is less than that. Now we are losing our face in front of CTs, and that's not well. So what is needed is do a transesophageal echo aortic root image with real-time 3D imaging. Just follow a simple steps and you get the results very quickly. What you need to do is you have to target it, and suddenly you'll find that it will give you a cast-like thing which you can turn, twist, and measure either which ways. Now this is under evaluation. At some point of time, for people, especially when you can't do a CT with the number of people are not few. There are large to sort out their imaging with contrast, and because of their kidneys will become norm at some point of time. I hope so. I'm a very strong protagonist of echocardiography. That's my bread and butter, and I just want this to be validated and pitched against CT scan, where we have already lost the race. Thank you very much for a patient listening, and I'll be happy to take any questions just in case there are any.